LVAD, the EMS Essentials. Welcome, and thanks for listening. My name is Dr. Ben Resney, and I'm an emergency medicine resident and soon to be anesthesia critical care fellow. I have a passion for teaching medicine and want to provide quality information in an easy to understand format. LVADs can be a complicated topic with associated complex issues. The purpose of this presentation is to provide a basic introduction to LVADs, and it's geared towards EMS and first responders, although other health professionals may find this useful. The format of my presentation is relaxed. I believe people remember and learn things better that way. There won't be tons of slides filled with paragraphs of text to distract you. Instead, there'll just be some pictures to look at while you relax and listen. Don't worry, I wrote down all the important stuff for you on a handout if you want it for review at the end. All right, let's go ahead and get started. Like anything in medicine, before we get to the good stuff, we have to make sure we do a quick review of the relevant anatomy. On the screen, you'll notice a diagram of the human heart. We'll begin with the vessel up here, which is the superior vena cava, drains the upper portion of the body and the head back into the heart. And here is the inferior vena cava, which drains the lower body back into the heart. This blood all drains back into a large pumping chamber called the right ventricle, which then pumps the blood through the pulmonary arteries to the lungs. Once the blood reaches the lungs, it becomes oxygenated before returning to the left side of the heart via the pulmonary veins eventually into the left ventricle, which is the major pumping chamber of the heart. This major pumping chamber pushes all of the blood from the heart back out into the body to the tissues to deliver the oxygen. This happens through the aorta. The problem is that sometimes this pumping system can go bad. You can lose the left ventricular function or the pumping function of the left side of the heart secondary to something such as a heart attack, which might kill the muscle in the left side of the heart, causing it not to pump as efficiently. When that left side does not pump as efficiently, then the blood can back up and go into the left atrium, back into the lungs, and even back into the right side of the heart and back into the body at its worst. Besides heart attacks, there's other conditions that can cause the pump to fail, such as high blood pressure, alcohol abuse, viral infections. The list is quite long. So the problem that an LVAD addresses is that of a broken pump, namely the left ventricle. That's where the LVAD derives its name, left ventricular assist device. Let's go ahead and take a look at what this looks like inside the human body. So this is a picture of an LVAD after it's been placed in the human heart. You'll note that before, where the left ventricle was failing and backing up, there's now a tube that connects the heart to a pump to help assist with that left ventricle's emptying. This portion where the arrow is called the inflow cannula because it creates inflow to the next portion, which is the actual LVAD itself. That's the pump right there. And then after you go through the LVAD, the next part is called the outflow cannula because the blood flows out of the pump and back into the body through the aorta. So basically this device bypasses the left ventricle. Now it's important to note that the heart still does beat on its own and some of the blood still does go through the left ventricle into the aorta through the normal route. The LVAD just provides some level of assistance to that heart. Now let's zoom out and take a little more comprehensive view of the LVAD device. You'll note the prior portions of the device we spoke of earlier. Plus now you can see this line here called the drive line. This is the main power source that connects to the pump that makes it go. This is partially tunneled under the skin, and then if you follow the line, you can see where it comes out and then becomes external to the body, where it plugs into the main controller. The main controller is also what you see on the left side of the screen there with an LED display. That displays all sorts of information, including error messages, battery power, the amount of RPMs the pump is spinning at, the power the pump is using, and it's basically your control source for the entire apparatus. Also note that on each side of the body there's two holsters. These are for holding the batteries. And if you trace the lines out of the batteries, you can see they also go back and connect to the main controller. All right, so now that we've got our boring background out of the way, let's go ahead and start applying some practical information. So let's say you're sitting at the station when all of a sudden a call comes across the radio for a 61-year-old male who has an LVAD. It started alarming, and he's becoming concerned. So let's grab our gear and head to the call. On a side note, when I was looking for photos to make this presentation, I saw this and it struck a personal tone with me. Reminds me of what it was like the first day on the rig, trying to act like I knew what I was doing, faking it till I make it. I think I probably look like this for most of the month, but things did get better. Anyway, back to the call. So you arrive on scene. Patient's sitting in his chair. He's awake and alert, speaking with you. He looks pretty stable. His LVAD is beeping loudly. Now keep in mind, many of the potential problems with an LVAD require intense, detailed interventions. Don't concern yourself with knowing all of these issues. These aren't things you're going to solve on the street. Our job instead is to stabilize the patient and get them to a capable colleague at a local LVAD hospital. So what can you do? First of all, start with the basics. Is the LVAD working? Given that the patient's talking with us, the answer is probably yes, but not necessarily. Listen for the hum of the LVAD. You can do this by taking your stethoscope and placing it over the chest or the epigastrium. If there's no hum, the batteries could be dead or the wire might be dislodged or damaged. Secondly, look at the controller. The LVAD controller displays error messages. It might be something simple that you can fix. For example, if the error message says battery, the replacement is simple. There's just a clip that locks the battery into each holder, and the patient typically stores many spare batteries in their house. Make sure you only replace one battery at a time. Some of the other alarms are more complex. Even as a doc, I'm going to struggle to fix some of these in the hospital. Just for exposure, though, I'd like you to be aware of some of the things the LVAD alarm might say. You might see something on there such as high flow/low flow error, high power errors, low PI errors. And again, this isn't going to be solved by us on the scene, even under the best circumstances. If we're lucky, we can stabilize the patient until we have enough time to get them to an LVAD center for these issues to be solved. One more note on batteries. Just like when you're using your iPhone in the airport, these things will lose their charge at the worst time. The patient will have a set of batteries and a charger at home. Regardless of any of the other interventions you do, you always need to remember to take the batteries and the charger with you. Now, common sense would make you think there'd be a bunch of spare batteries sitting around the hospital, but you know how difficult it is to even find a spare pillow in the ER, so assuming the hospital will have LVAD batteries or a charger is a dangerous assumption. Okay, quick recap. So we've arrived on scene. We determined the patient is stable. We've checked the LVAD and can hear the hum of the pump. The batteries are working, and we've collected the spare batteries and charger in preparation for transport. So what's next? Even in complex patients, you always need to go back to the basics. Remember, vital signs are vital. Obviously, respiratory rate and temperature are not going to be any different in an LVAD patient versus a non-LVAD patient, so those two are easy. But what about the heart rate? Well, think about it. The heart is still beating even in an LVAD. You should be able to obtain a heart rate on an automatic monitor. The heart still has electrical activity, and the monitor should still record this. This is the case even if the patient is in an arrhythmia, but there'll be more to come on this issue a little bit later. Blood pressure, on the other hand, that's a little different. Because the LVAD is working as a continuous pump, systole and diastole are altered, so obtaining an accurate blood pressure can be difficult. How are you going to obtain this patient's blood pressure? Because blood pressure cannot be measured as accurately in an LVAD patient, studies were done to determine the most accurate way to check a blood pressure in an LVAD patient. I'm going to talk about a study by Bennett et al. In 2010 published in the Journal of Heart and Lung Transplant. What they did was they put a measuring device directly into the artery, which allows them to directly measure the patient's blood pressure. Only the researcher could see results of this. Then they had somebody else check the blood pressure in a more typical way, such as with an automatic cuff or by auscultation with your stethoscope. They compared the actual blood pressure seen on the arterial line with that of the value reported by the healthcare worker taking the traditional measurement. And they compared those for accuracy to each other, and the results were interesting. With the automatic blood pressure cuff, the healthcare worker was within 10 or 20 millimeters of mercury of the actual reading within 55% of the time. When they did the auscultation method using the stethoscope, they were accurate about 15% of the time. And this is interesting because a lot of times in the field, if the automatic blood pressure cuff isn't reading, we'll switch to the traditional method of auscultating for blood pressure. But as you can see in patients with LVAD, this results in quite a large drop in accuracy. The most accurate way was by something called the Doppler method. But again, this is something you won't be able to do on the scene. So it has to be performed in a hospital typically. And so that's off the table. So looking at these results, the most accurate method of measuring blood pressure in a LVAD patient is through the automatic cuff. But it's important to keep in mind that that's only going to be accurate about 55% of the time, or 1 in every 2 patients. So what does this practically mean to us? Well, since you're unable to do the Doppler at the scene and get 90% accuracy, we have to look at the patient and use common sense. We have to check for signs of perfusion. Do they have good cap refill? Are their extremities mottled, or do they look like they've got good blood flow? Some common sense plays in. Okay, so let's change this up for a minute. Let's say this time you arrive on scene, but the patient looks unstable. You hook up a 12 lead, see that they are in sustained VTAC. They're diaphoretic, short of breath. They just don't look very good. This patient has an LVAD. What are we going to do with them? Step 1, check your own pulse. Make sure you're not also in VTAC. Although this situation sounds scary, you can take a deep breath and relax. This isn't going to be much different than a normal code. Next, if the patient is unstable with an arrhythmia, then you need to cardiovert them just like you would with any other unstable arrhythmia. Make sure you do this per your department's protocols. There are, however, a couple of caveats when you're doing this with an LVAD. Caveat number 1, place the pads in an anterior and posterior configuration. And the second thing to remember is that it's recommended that you disconnect the LVAD from the controller very briefly while you do the actual cardioversion. So that's an unstable arrhythmia. What if you show up on scene and the patient's actually in a stable arrhythmia? There's no chest pain, they're not syncopal, there's no dyspnea, their vitals look fine, etc. In that case, your end goal is to get them to a nearest hospital quickly for pharmacological intervention. Depending on your protocols, you might be able to start some of these drugs during transport. However, given this is an LVAD patient, I would really recommend you speak with one of the doctors prior to starting any of these medications. Now keep in mind, it's not uncommon for an LVAD patient to be in an arrhythmia because they have very sick hearts. Also, the scarring from the surgery can make them more likely to be out of rhythm. So if they are indeed stable, do not cardiovert. So we've spoken about unstable arrhythmia and stable arrhythmia. Now let's go to the biggest of all, the cardiac arrest. Let's say you show up on scene and the patient's actually in cardiac arrest. Again, this isn't going to be that difficult. You're going to treat them the same way as any other patient in cardiac arrest with the standard ACLS guidelines. You practice these a lot, so you should be pretty good at them. Again, a couple caveats. Make sure you have anterior and posterior placement of the defibrillator pads. Disconnect the LVAD briefly during the defibrillations. And with the coding patient, there's a little bit bigger controversy. The manufacturer of the device recommends against chest compressions because they're afraid that the LVAD tubing could become dislodged from the trauma of the compressions. A lot of clinicians disagree with this, though. And in fact, there was actually a small study done in 2014 that suggests compressions do not cause harm. I put the information for the study down below here, but basically what they did is they examined a small number of patients who received chest compressions with an LVAD. None of the patients in the study had any dislodgement of the device or any of the tubing. One patient actually received compressions in the study for 2.5 hours in the back of an ambulance prior to arrival at the hospital, and there was no dislodgement. So do you do compressions or not? My opinion would be the patient does not become much deader than dead. Now, keeping in mind the caveat that it's difficult to get an accurate blood pressure on scene, if the patient does not have a blood pressure, does not have a heart rate, is otherwise appearing to be dead, then I don't see any harm in starting the compressions. Keep in mind, though, that there is still some controversy in this area. Now, it's okay to zone out for the next minute or two during this slide. I'm just really including it for the sake of completeness and in case you have a further interest in LVADs. We've already discussed most of the essentials that you'll have to know about LVADs when arriving on scene, but there are several other complications that I would like to make mention of. These are generally not treatable on the scene, but just so you have an awareness of what they are, let's talk about some of them. First of all, bleeding. The LVAD actually tears up platelets, plus these patients are usually on blood thinners, so GI bleeds are a common LVAD complication that you'll run across. Secondly, you can get a clot in the pump. A clot forms inside of the pump or the apparatus and clogs the device up, which can lead to some issues. Again, this needs to be treated at the LVAD hospital. Third, uncontrolled blood pressure. If there's uncontrolled high blood pressure, it makes it difficult for the pump to work properly because of all the increased resistance. Due to this, the patients can have a stroke from loss of blood flow to the brain. And finally, infection. Just like a central line, dialysis access, or any other tube into the body, LVADs are susceptible to becoming infected. So those are the major issues. If you tuned out for the last minute, now would be the time to focus back in to the presentation so we can wrap things up. So hopefully by now you are more familiar with LVADs. Like I said at the beginning, this is a complicated topic, and this presentation is meant to just discuss a few high-yield points to increase your familiarity. Here's a brief review. 1. When you first arrive on the scene, make sure you listen for the hum, check the batteries and the connections, and read the alarm code. Remember to bring the batteries and charger with you to the hospital. 2. Vitals are important, but keep in mind that the best method available to measure the blood pressure on an LVAD patient is the automatic cuff, and it's only accurate about 50% of the time. Remember to use your clinical judgment to assess perfusion. 3. A stable arrhythmia. In this case, get to the nearest hospital for pharmacological stabilization. 4. Unstable arrhythmia. It's okay to shock the patient. AP pad placement, disconnect the LVAD from the controller briefly while you do the shock. And finally, a coding patient. There is controversy about compressions, but it is okay to compress and shock. Make sure you place the pads in the AP position, unplug the LVAD from the controller as we spoke about with the unstable arrhythmias. That's it. That's the end of my first ever video presentation. If you enjoyed this presentation or have a question or suggestion, leave a comment below. Thanks for listening.